This is the second in a series of 3 webinars focusing on breastfeeding issues for GPs and GP nurses. Stefanie Preissner talks to Professor Afif EL-Khuffash, Consultant Neonatologist and Paediatrician, IBCLC from the Rotunda, and Laura Dowling, Pharmacist, fabÜ founder and winner of the prestigious 2022 Pharmacist of the Year Award. Here they talk about the misconceptions around the use of medications when breastfeeding. Hope you enjoy.
Welcome to the next segment in our webinar series. I'm Stefanie Preissner, and on this panel we have Laura Dowling, also known as the fabulous pharmacist, and we have Afif EL-Khuffash. Do you guys want to just say a little bit about yourself so people know who you are?
Sure, I'll let you start, Afif.
Okay, thanks, Laura. My name is Afif EL-Khuffash. I am a neonatologist at the Rotunda Hospital, and I'm also a professor of pediatrics at the Royal College of Surgeons in Ireland. And over the last 7 years, I've also become an IBCLC, so a Board Certified Lactation Consultant as well.
My name is Laura Dowling. I am a community pharmacist working as a pharmacist for the last 20 years with a special interest in women's health, and particularly mothers and breastfeeding and medications that they can take when they breastfeed, rather than telling everyone that they can't take anything when they breastfeed. So that's my interest there.
And that is the topic of this webinar, this segment of the webinar, which is medications and breastfeeding, how they interact, what you can and can't take, and I guess to educate people watching so that they can pass on this information and empower breastfeeding mothers so that they don't feel terrified of everything. So I might just hand it over to you to give an explanation about that topic.
Fantastic. I'll let Afif discuss the transfer of drugs through to the breast milk and why some drugs are okay and some drugs are best to avoid, and we'll go from there. I think we'll just have a conversation back and forth, Afif, yeah?
Yeah, great. Thanks, Laura. So we all know that our breastfeeding rates in Ireland aren't great and we need to improve them. And just to give you a bit of context, 80% of mothers intend to breastfeed before they deliver their baby. That actually drops to only 35% of mothers exclusively breastfeeding by the time they leave the hospital. So a huge drop off in the first, 2 to 3 days. And by 6 months of age, there's only 10 to 15% of mums that are exclusively breastfeeding. And I think a significant contributor to that is the fact that mums are of an increasing age now, and they have, comorbidities. There's an increase in the use of medication. And because there is relatively little data about the safety of medications during breastfeeding, I think a lot of healthcare providers and mums themselves sometimes make a hard choice with discontinuing breastfeeding in order to continue taking the medication that they need to take. And we all know that by and large, a good number or a significant number of medications are actually okay. But our disadvantage is that there aren't a lot of studies that look at the level of drugs in breastfeeding and whether they cause any adverse effects in babies or not. And the reason for that is that, unfortunately, drug manufacturers and those that are involved in research usually exclude breastfeeding mothers and pregnant mothers from that research. And there's a lot of reasons for that. A big contributor is fear of litigation, because you're not just dealing with one person, you're actually dealing with a mother and a fetus or a mother and a baby. So there are a lot of challenges with that. However, consequently, we end up with a lack of knowledge on medications and breastfeeding. So unfortunately, though, we have built up a big database of how a lot of medications actually work in breastfeeding. And what's important to know as well is the laws or the rules that govern the transfer of drugs from mom to baby, or from breast milk, or from the maternal blood or maternal plasma to maternal breast milk. And I'm not going to dwell on those, but these things that determine these things are, the size of the molecule of the drug. The bigger it is, the less likely it's going to transfer into milk. Whether the drug is soluble in lipid versus water, whether it likes to be in fat or likes to be in water. Drugs that like to be in fat are more likely to be transferred into breast milk. And a big important example of that, all drugs of abuse, for example, people things that people use drugs, recreational drugs. I mean, they are of a low molecular weight, so they're very small, and they love attaching to fat. So drugs like this accumulate in breast milk very, very quickly. And another thing that determines them as well is the actual concentration of the drug in the maternal plasma. So the quicker the drug builds up in the mother's plasma, the quicker it's going to build up in breast milk, and once it is removed from plasma, it is removed from breast milk. So knowing these basic principles can actually sometimes help inform us as to whether a drug can be taken during breastfeeding or not.
Absolutely, yes. And there is lots of data that has been compiled, and isn't necessarily clinical studies that have been done, but it's observational data over a period of years. There's been a lot of work done by a lady called Dr. Wendy Jones. She's a pharmacist over in the UK, and via her own breastfeeding journey herself and the considerable lack of data around medicines and breastfeeding that she found when she was breastfeeding her children, she actually set up a network and also did lots and lots of research in this area, to the point that there is a huge amount of data on the breastfeeding networks, drugs and breastfeeding fact sheets that I would often have referred to in practice. And there's also an app called LactMed that gives considerable amount of information. So there really is a huge amount of data. And then there's also as well as the comorbidities that come with the mother's age increasing, there's also a lot of OTC medicines that ladies can avail of, or OTC therapies that ladies can avail of if they have, for instance, coughs, colds, suffer with hay fever, etc. They don't have to suffer with them without seeking out remedies, either simple things such as steam inhalations that some ladies don't even realize they can help themselves with, down to decongestant sprays that aren't transferred into the systemic blood supply, and therefore aren't transferred into the milk. So there's lots of options. So what Dr. Afif and I decided to do today was pick out the top, say, 5 or 6 issues that we would see in practice, and give a little bit of information as to how women can navigate the journey of how to help themselves, and how their prescribers and doctors can help them too.
Okay, I suppose let's go straight for it. We have about 12 minutes left, so let's go through some of those medications to give people that information.
Okay. So Afif, do you want to talk about antidepressants and anxiety?
Yeah. Okay, maybe we'll start with those. I mean, by and large, the selective serotonin reuptake inhibitors, those are the commonest drugs that are used for mums with anxiety or depression, are generally safe to use during breastfeeding. There are ones that aren't, but the vast majority of them are. The particular thing that I want to talk about is the benzodiazepines as well. Sometimes they are prescribed or used either short-term or slightly longer term for treatment of anxiety. We wouldn't recommend the use of diazepam while a mum is breastfeeding, because it has a long half-life, meaning that it stays in the system for such a long period of time. It is lipid soluble, meaning that it loves fat, so it transfers into breast milk very quickly. So this one we advise to avoid during breastfeeding. However, it does have a different counterpart, lorazepam, which has a much shorter half-life. It is protein bound and has poor lipid solubility, so all the characteristics that prevent it from transferring into breast milk. So this is an example of a way of actually managing anxiety in mums, where you can find a drug that has the same effects, if you like, but doesn't transfer into into breast milk as readily as the other one.
Yeah, absolutely. And the selective serotonin reuptake inhibitor of choice for depression and anxiety will be sertraline. However, others can be used, particularly if the woman has been on, say, something like escitalopram before and has got on very well with that. And there is data there to help the ladies. I suppose antibiotics would be the next thing that we would be interested in talking about.
Yeah, and antibiotics, it's generally an easy one to do, is in that most antibiotics are safe to use during breastfeeding, especially the ones that are commonly prescribed. So penicillins, cephalosporins, macrolides are all generally safe to use during breastfeeding. Now, there is some data to suggest that providing the baby with a probiotic while the mother is breastfeeding can actually help ameliorate the potential tummy upset that a baby might get if a mum's taking antibiotic. But I don't want the mums to be worried. Most of the time it doesn't happen. If it happens, it's mild loose stools for a few days until the antibiotic clears from the system. It is never a reason not to take antibiotics as a mum, if a mum needs to while they're breastfeeding. So the majority of antibiotics are safe as well. Antifungals, the topical ones especially, you know, the creams that you need to use for thrush and whatnot, are also safe to use.
Yeah, absolutely, and that's important. Even the single oral dose of fluconazole as well can be used in instances where the mum just can't get rid of the thrush infection. So that's also an option, which is important for people to note as well. However, if a lady is given the correct advice about how to deal with thrush and even deal with candida infections on the nipples, it can generally be got rid of without taking the oral medication too. So that's important. It's all about the correct counselling and I suppose use of medicines as well, particularly if the lady has thrush on her nipple and the baby has it in his mouth. It's important that the two are treated together and for the period of time that they need to treat it in order to get rid of the infection.
Great. So what about pain relief?
Yeah, so pain relief is something that pops up a lot, obviously, and women can need pain relief for any manner of issues, such as your typical back pain, your joint pain. Some ladies have carpal tunnel syndrome as well when they're breastfeeding, particularly in the early phases of breastfeeding when they've just had their babies. It's just one of those things that can happen. It can be very debilitating for ladies. And then your coughs and colds can give headaches. Ladies are tired when they're breastfeeding too, which can lead to headaches. I often say to women, if they could just get their baby minded and get to bed and get all the cooking and cleaning and laundry done, they'd recover a lot quicker. But we're living in the real world here, and sometimes it is the case that they do need the medications. Paracetamol is perfectly safe for a woman to take when breastfeeding, particularly the 2 500 milligram tablets QDS. That is fine for her to take up to the maximum dose. We obviously recommend that she takes the lowest amount necessary, but we don't want her taking subtherapeutic levels because that's not going to help anyone. So she's better off taking the 1 gram dose, seeing how she gets on with it. She can take ibuprofen as well, and that's no problem. And a lady can also she can take ibuprofen, and her baby may need the Nurofen or ibuprofen liquid if the baby is over the 2 months and is teething or something and she wants to give the baby the product as well. There isn't that crossover with the medicines if mum's taking it and baby's taking it, because sometimes mums and babies get sick at the same time. They're obviously in such close proximity to each other. So that's important to note. It is important that women understand and doctors understand that codeine and the use of opioids is not recommended unless under supervision. So obviously we'll see it post delivery if a lady needs pain relief, particularly if she is post section. She might be given opioids, but generally it is not recommended for a lady to have opioids because it can transfer into breast milk, make baby sleepy, cause respiratory depression, etc. So it's advised to be certainly avoided in the pharmacy setting, and only under if a woman is supervised and given the correct details. If it is an opioid that is advised, the oxycodone is the opioid of choice, but there is certainly ways that women can manage their pain when breastfeeding.
Great. And I think another important group of drugs that we need to discuss are decongestants and antihistamines as well, because the use of them, especially over the winter months, is going to be quite high.
Yeah, absolutely. And, there is this misnomer that women just can't take any antihistamine, and that's just absolutely not the truth. Women can take short courses of non-drowsy antihistamines. So that's your loratadine, your cetirizine, and even your fexofenadine there is data there to say that it is safe too. But we would start with the loratadine, the cetirizine first. Obviously, they're generic and nice and cheap as well. Women can buy them over the counter and not have to be out of pocket too much. The fexofenadine is considerably more expensive. And I would only really recommend that if the loratadine and the cetirizine hasn't worked. Short-term use is fine for this, and that short-term use, what defines short-term use? If a woman has, runny nose and bad hay fever symptoms, she can have that all summer. So technically, a woman could be on that, for a number of weeks, and it wouldn't be considered to be something that would be bothersome. The non-drowsy antihistamines, on the other hand, such as Piriton and that, when we say short-term use for that, we would mean a couple of days, and that's for things like urticaria and things like that. So we would be leaning towards the non-sedating antihistamines in those instances. In terms of decongestants, oral decongestants really wouldn't be recommended. Sure, they wouldn't, Afif?
No, and one of the big things that we caution against decongestants that they can actually reduce your milk supply.
Yeah, exactly. So that can have a knock-on effect with just your breastfeeding journey in general. And the last thing we want to do is to reduce a lady's milk supply. And, particularly if a woman is sick, she may not be looking after herself, eating well, drinking enough too, and her milk supply by default, just out of tiredness and that, can decrease anyway, particularly in the evening time. So we want to do everything that we can to keep her supply as optimal as possible. So in terms of the decongestants, they can use decongestant sprays because they aren't absorbed systemically. They just work on the nasal mucosa to help to open up or to help to constrict the blood vessels there to help with the congestion. And they can work perfectly fine, as can steroid in nasal sprays too. But we need to make sure the lady understands that when she does take a nasal steroid spray for things like congestion or hay fever, that it does take time for that to work. So I would often recommend the co-use of, say, a quick-acting decongestant plus the steroid until the steroid kicks in. So that would be a number of days on both, and then you can reduce off stop taking the nasal decongestant and just continue on with the steroid indefinitely, particularly during the summer months. Always important to tell a lady that if she is using a decongestant nasal spray, and that not to overuse it. They can get rebound congestion within 7 days of use. That can cause considerable symptoms to come back, but also be even worse than they were originally. So it's always really important to say to them that just because they can't take tablets doesn't mean that they can use the decongestant nasal sprays long term without having those kind of rebound effects. And what's actually brilliant for decongestion as well, and people kind of forget it, is the nasal sprays. They're brilliant. The steroid nasal sprays, not steroid nasal sprays, sorry, the saline nasal rinses. So you have your Sterimar, which is the spray, but I actually love the Neilmed. It's wonderful because it's a little bottle with your little sachets and you just make it up. But sometimes that can work out expensive if people need to use that a lot. So they can actually just use a little neti pot. You can buy them in like your little health stores or yoga places. And so long as they're using like a salt that isn't normal table salt that's iodized, if they're using like a natural salt, they can actually just make up their own salt solution too, and it'll save them a lot of money, particularly if they need to use that a lot. And the nasal rinsing can be done as many times as they want, 3 times a day if they need to.
Great, and I think we have a couple of minutes left, so I thought it'd be important to also mention we get a lot of questions about, are there any medications that can increase milk production and increase milk supply? And we know that domperidone, which is a dopamine antagonist, can increase prolactin levels, which is the hormone responsible for increasing milk production. And I suppose the thing to remember with that is that it should only be done with consultation of a highly experienced lactation consultant or your healthcare provider, and it should not be a replacement for proper breastfeeding and lactation support in terms of optimizing the latch, optimizing the positioning, and making sure there are no mechanical impediments to milk transfer, such as a tongue tie or something else like that. So it definitely wouldn't be the first port of call for boosting milk supply until all of the other things have been addressed first. There are certain situations where mums may naturally have low prolactin levels, where domperidone may be of benefit, but it's not something that we would generally recommend to be used in a widespread manner.
Yeah, absolutely. And it's important that the woman is, fully up to speed on the possible side effects that can happen with domperidone. Now they're rare, but, they can get headache, dry mouth, etc. But then also anyone that has heart issues or that is on drugs that prolong the QT interval cannot take anything with domperidone in it. So that's important. Also, it's worth noting, actually, there's lots of kind of, old wives' tales going around about particular herbal remedies that can increase milk supply, such as fenugreek, etc. the data on them isn't amazing, to be honest with you, and the woman is probably just going to end up spending money that she could otherwise spend on maybe a cup of coffee.
And yeah,
So,
and lactation cookies that go full 12 euro a pop as well. Save your money and buy 3 normal cookies for the price of 1 lactation cookie.
absolutely, I would agree. Ditto the encapsulation of the placenta. I don't think there's any evidence to suggest that increases milk supply either. So I'm sure I'm speaking the converted without when I'm talking about that, but I suppose it's just worth noting some of the things that ladies may be going into and feel very strongly about because they've read it or heard about it online or on forums. There's no real data to suggest that they work or that they're safe either. That's really important to note. Particularly with microencapsulation of the placenta, I would be, oh my goodness, the amount of aseptic control you have to do when you're doing that, I would just be, very nervous about that.
Thank you both so much. I hope for those of you watching and listening that was helpful. That was Dr. Laura Dowling and...
I'm not a doctor. I'm not a doctor. I'm a mere pharmacist.
That was Laura Dowling and Afif EL-Khuffash. And yeah, we're going to finish up there and go back to our panel.